All right. Good afternoon, everyone. Welcome to the next webinar in the 2022 Clinical Trials Methodology course webinar series. My name is Courtney Miller. I'm the project manager for the course, and I'm glad that you all can join us today. Before we get to today's topic, I do want to remind you of a few things. If you have any questions or comments, please use the chat box, the Q&A feature, or since this is a Q&A webinar today, just go ahead and raise your hand and I will unmute you so that you can speak. Additionally, please complete the evaluation for today's webinar so that we can improve future webinars. I will go ahead and put the link in the chat box. Our next webinar will be What to Know About Sample Size, presented by Sharon Yates at the Medical University of South Carolina, and this will be on June 10th. You can find our full webinar schedule on the course website. So for today's webinar, we have an open forum Q&A, and this will be presented by our course directors. We're joined by Drs. William Moyer, Lori Gutman, and Robin Conwit. They're here to answer your questions on neurological trials and help think through ideas to move your research forward. Thank you so much to our course directors. And with that, I will turn it over to Dr. Moyer.
Thank you, Courtney. I know that many of you have been diligently working on your protocol development so far within your small groups. And one of our goals here was to help basically with kind of hear about successes and challenges that some of you may be having in terms of designing clinical trials. If any of you are not part of the course cohort this year, that's also okay. And I think we can have a general talk about how to potentially design trials. I think right now, we were hoping to get some thoughts about things that seem to be things that seem to be going where you're like, oh gosh, I'm not exactly sure what to do next with my design process. So with that, if people want to either raise their hands or put something in the chat, and Dr. Conwit or Dr. Gutman, if there's anything you want to add.
I think one big topic that keeps coming up is avoiding an underpowered efficacy study. A lot of the clinical trials methodology attendees start out with an idea of doing a smaller efficacy study, but that's not really the best idea for this type of pilot evaluation. I don't know if any of you have had that experience.
I think, yeah, no, if anybody from the audience, the attendees wants to raise your hands. I think also we would be interested in terms of what sorts of advice you may have gotten in the past and so forth in terms of how to do exploratory phase trials. Because I think Dr. Conwit brings up a good point in that, particularly in the neuro space, we are very worried about underpowered efficacy studies because you get kind of noisy results that are hard to understand exactly what to do with going forward. So, but I can expand a little bit more upon that. But I would love to hear from anybody out in the audience about their experiences, like both in terms of sort of struggling with this in your current design, or just how you've been sort of taught this before, so to speak.
One thing I will say, Will, is that there are some people who are on the webinar who are not in the course itself too, and they're also welcome to bring up questions of any concerns, and especially as we talk about the underpowered efficacy studies. I mean, I will say in my small group, we have 3 different disorders / diseases that are rare. And how do you deal with the design of a trial that will eventually build into an efficacy study when you have when subjects are difficult to come by, or you want to use your study as efficiently as possible to get the information that you need because it's such a rare population. Maybe I'm off on a tangent here.
No, I think that's an important area. And I think one, in terms of rare diseases can present challenges for a lot of reasons, but particularly rare and progressive diseases, there is a lot of impetus to have there be some focus on changing the trajectory of that disease. So that's, how you incorporate the right goals of the trial so that you can learn about what the right next steps are is important. One other thing that I can just share, I'll just share my screen here briefly, is the NINDS has a if you're going to do a exploratory clinical trial, has a funding announcements PAR 21236, and the if you search for the term underpowered in it, you can see that even though this is the exploratory trials mechanism, so for phase 2 trials or earlier, it's not intended to support the conduct of a clinical trial where the primary aim is to establish or confirm definitive efficacy. And it goes on to say, while an exploratory clinical trial may examine clinical outcomes or biomarker outcomes as measures of preliminary efficacy as a secondary aim, it is important that it not appear to be an underpowered efficacy trial. And going on to think about, a trial will not be considered for funding under this FOA when its primary objective is to estimate intervention effect size to be used in power calculations for a future efficacy clinical trial, because effect size estimates based on smaller short-term studies are often unstable or unreliable. So that encouraging you to think about the smallest clinically meaningful effect size, which can sometimes be hard, but can often be determined by surveying physicians or patients, or by comparing to effects of existing interventions in the disease you're studying or possibly related diseases. So these are, this FOA gives some of the sort of thinking of NINDS, but also the thinking of leaders in the field in terms of how to design neurologic trials. And again, how much variability there is in your outcome measure or endpoint, and what is the optimal timing to see an effect of an intervention. These are things that are potentially important things to try to learn about in an exploratory study, or a clinical trial that is prior to the efficacy trial. I think Dr. Gutman brings up a good point that if you're studying a rare disease, you get into a bit of a catch-22, because for a multi-center trial, oftentimes people want a more definitive efficacy type trial. But if it's a rare disease, you may need, you're definitely going to need multiple centers, even for the more exploratory phase trials. So that can sometimes present this catch-22 of how to collect enough information about a rare disease in order to get the funders and study sections excited about studying it further. But I guess if there are people in the audience who, I know that there's some people who are designing very interesting trials. And I think I don't want to necessarily call on people. I feel like this is my my 8th grade science class. But since for those of you who are either outside of our cohort, who we haven't talked too much before, or thinking about maybe participating in future years, I just love to hear like what sort of areas you're looking in. And then if you are one of our current year course participants, since potentially since I'm not leading your small group, hearing a little bit about how things are progressing for your projects would be interesting.
So, Will, there's something in the Q&A. Do you have any cautions or advice for studies of novel methodologies based on reanalysis of prior trials using that novel methodology?
Let me think about that for a second.
Yeah.
Any cautions? I think so. I guess I will give a preliminary sort of thought, and then I think it would be maybe help, if the person wants to give a little bit more detail, that would be helpful. So one thought would be, if you're using, in terms of a methodology, let's just say maybe it's a novel statistical methodology, like, and again, novelty is somewhat in the eye of the beholder, but maybe something that hasn't been applied to your clinical problem, so to speak. If that has been previously applied to something that is really well characterized, right? Like, I hate to always use stroke examples, but if there was some way of analyzing data that used a novel methodology and was applied to the NINDS-TPA data as a example, then that might give people comfort that it would come to the same conclusions as the main analysis of that trial, or could come to different conclusions. I think the big thing I would caution about with respect to applying novel methodologies to pre-existing trial data or observational data or other places is, typically we know what those studies showed, so that to some degree it's not the same as, if you apply some analysis technique to a trial from the past, how that trial turned out, so you can see how your new method worked versus that. But in the future, there may be important differences in the population that would be not captured in the future clinical trial population. So you may not know how the novel method would actually perform, quote unquote, in real life in a future situation. But that's pretty hand wavy. So if whoever asked that question wanted to like kind of put a little bit more detail on it, I could probably give I think either myself or Dr. Codwin or Dr. Gutman, we could probably give a little bit of a better answer if you were able to unmute and present a little bit of more context as to like the exact sort of use case.
If you want to unmute, you can just raise your hand, and there's the raise hand thing at the bottom, and we can do that. So here's neuroimaging biomarkers for cerebral blood flow, or something's wrong with my computer and the words are all blurry.
Oh yeah, I see it. So how do you think about using neuroimaging biomarkers, say for instance, cerebral blood flow on MRI, ASL, ASL in terms of underpowered efficacy studies? So I think if, I guess it depends on the disease case. If there is, it depends on what your goal is. If your goal is to say, I want to improve blood flow, right? Like maybe somebody with a chronic internal carotid occlusion. Can I give a medicine that will augment their blood flow and improve things? Or can I improve, or in a chronic disease, can I improve cerebral blood flow to reduce the burden of chronic progression of cognitive decline? I think if you think that blood flow is what is mediating the process, showing that your intervention can improve blood flow might be helpful, but I think it depends on how plausible that relationship is. I think I would often think of sort of blood flow in terms of MRI, because I often think of stroke. If I had a good study where I could look at infarct growth, right, based on initial penumbra versus final core volume, and how much I could change that within individuals by using a neuroprotective, I would say that a study like that is showing proof of concept that your agent is reducing final infarct volume potentially compared to a control condition. And in that, it's not really an efficacy study, you're using an imaging biomarker, but we have like some planned, we could talk about biomarkers and how to consider them as, whether they're pharmacodynamic, whether they're prognostic, the whole classification of biomarkers. And I think since that's a little bit beyond the scope of what we're going to talk about today, is I can put in a little resource into the chat for everyone about just a way of kind of considering biomarkers, something called the best biomarkers type statement from FDA, I think. So I'll put that into the chat so people can kind of chew on that a little bit, but there'll be more future discussions about biomarkers, and we have some good recorded lectures where we go into biomarkers in a bit of detail. So I'll try to put a couple of those things in the chat. Oh, okay. Yeah, and we did get the follow-up that using a novel statistical method. Yeah, so in terms of, is that, can you get to an answer sooner? And I think you just have to be cautious. The other major caution is if the statistical method is doing something that helps limit variability, control for confounding and some of those other things, and it makes your study more efficient and that it can get to an answer with less patients or less time, I think it's just always important to kind of think about all the assumptions that go into that. If adjusting for age in NIH stroke scale is very common in stroke studies, and that potentially can make studies a bit smaller because you're accounting for some of the variability that occurs in terms of the final outcome based on those important prognostic factors.
Yeah, I think the most important thing is just making sure that you vetted this really tightly with a biostats person who's going to give you feedback, not just someone who will give you a power analysis and tell you to go ahead. I think that's how you sometimes get burned by. So making sure that as you're designing the study, not just taking it to them and saying, this is what I want to do. To have useful biostats input really is what's going to give you the most, the best ability to shorten your study in a way that isn't going to hurt your outcomes of the study. I don't know if that was coherent or not. I think it was.
No, I think that's exactly right. And I think if sometimes it's also a novel way of using a sort of standard biomarker, like for example, utility weighting of the modified Rankin in stroke studies. I think the that's, you know, becoming more accepted, but people feel pretty strongly on different ways about it. So ensuring that you know people who can kind of, you know, smart biostatisticians that can kind of give you sort of the benefits, risks, and potential plus minuses of a novel technique versus a quote unquote more traditional technique. I think at the end of the day, it really depends on the situation and how the like underlying advantages of the new thing interact with what the population looks like and how the variables all interact.
We do have a couple questions in the chat and then one trainee sharing their specific aims. I can go ahead and read that. One trainee said they're no longer looking at clinical efficacy as their primary aim, at least as far as I can tell. The primary endpoint is more of a change in CBF and edema rather than a clinical scale as an endpoint. I'm not sure if that makes a difference. You want to comment on that?
I think if Aaron, if you're comfortable popping up there, we'd love to kind of see those things. I think like I was saying, if reducing edema and improving cerebral blood flow is something that's on the mechanistic pathway, and you can alter that with a treatment, yeah, I would agree. That's not really an efficacy aim. I look at that as you know, sort of establishing proof of concept to a certain degree. Although I like to call things proof of concept a lot, but I don't know if we want to give Aaron speaking rights to just talk a little bit more about the study and the ideas.
Yeah, hey, thanks a lot. Yeah, like my idea is really to use Provigil or modafinil in basically acute stroke patients very soon after the stroke. And there's definitely some data out there that modafinil improves cerebral blood flow in these patients, and some very small, like underpowered studies that showed efficacy. And so like my idea is really more kind of an exploratory trial looking at patients, cerebral blood flow and kind of peristroke edema after acutely getting modafinil after the stroke. And so that's kind of why I was wondering about that.
Yeah, I think from the perspective of, you know, you have a potential mechanism, you have a, you know, target population, you have, you know, the thing that's sometimes tricky, I think, is, and you know, hopefully you have the right like radiology collaborators, you know, what you're using to define, you know, what constitutes edema, you know, using, you know, some quantitative volumetrics, ideally that perhaps are sort of married to ADC. But I think as a conceptual model, you know, the thing that's always a little tricky is if you don't move that stuff at all, you know, is it sort of good, like move on to the next treatment? This is probably not going to work on a larger scale. If it works in terms of showing this proof of concept and showing that you can move the needle on these things, then I think it's great. I think the thing that's crucial about designing those sorts of studies is having some preliminary data about the progression of the volume of infarcts and stuff over time within you know, historical controls or others with the disease, you know, in terms of measurements that are at approximately the same times, knowing that in clinical practice, when we might get MRIs and so forth, can vary a little bit by institution and the strain on the magnet, so to speak. But I don't know, Lori, did you have anything else? But I think that's a very cool, I mean, I like that idea. I mean, I think the other thing is, I mean, acute stroke is an area where even with the exciting new reperfusion therapies that exist, there is a relatively small number of patients in whom we can actually offer treatments to. Many patients don't qualify for any treatments, but something like modafinil maybe could broaden the number of people we could treat safely, which is also really, I think, exciting.
Yeah, no, I think I don't have anything to add to that. It is interesting though.
All right, so I think the next item over in the chat from Dr. Lowe, suppose you are collecting data testing feasibility of an intervention in a small sample, say 5 to 10 subjects. Your data seems to demonstrate feasibility. How do you decide whether you need more feasibility data as opposed to you're okay to propose a pilot trial? I think that's a great question. And I think it's also a question as to sometimes the definitions are murky, right? Like, what's a pilot trial? What's a feasibility trial? And what are the differences of those things? I think if let's say it's a really intense behavioral intervention, and you're like, you got a text message, blood pressure's back 2 times a day for 3 months, and you and I don't know how you convince people to do this. It may be because you might have to pay them a lot. That might be one way to do it. If you pay them $100 a day or something. And again, I'm not saying that that's a sustainable study design, but just as an example. So you do that in 10 people, and you find that if you pay people $100 a day, they will return 2 blood pressures to you a day. So that at least in terms of that aspect of things, can you get people to return blood pressures by paying them $100 a day? You do demonstrate some feasibility in 10 participants, right? Like all 10 are like, give me my $100 for each day for 3 months of blood pressures. So that, would I be convinced as I look forward to kind of doing the next study that, you can build upon that and say, well, what's, can I make their blood pressures change by, adding in a lottery, right? Like every day that your blood pressure is under better control, like, you get a chance at, getting $1,000. Now, I think if I was doing that design though, I would want to be careful about having some ability to capture the blood pressure in a monitored environment to confirm it, right? Like, because they're gonna, if you've been selected to win the $1,000 in the blood pressure lottery study, people would just give normal blood pressures all the time. So you would have to have some design elements that sort of combated that. But I think if you have but other things are like, you have a 4-hour assessment for a disease like dizziness in the emergency department, and if you find 10 people who are willing to do that, that's great. That moving on to another study where you're collecting data, that's important. But if only 4 out of the 10 people are actually able to tolerate a 4-hour set of detailed vestibular tests in the emergency department when they're dizzy, then you may not have demonstrated feasibility, and you may have to think about, can you pare things down? I think some of the others are, but so in terms of how well your study procedures can be tolerated by the participants, demonstrating that in an early feasibility study, potentially you can move on to other questions or gather even more information about feasibility as you try to move on to like a more proof of concept type question. But that's a good question. And again, if there's other questions, please keep popping them into the chat. Dr. Makani has a really good question of, what are the pros cons of randomizing versus using historical natural history data as a comparator in an early phase trial? I don't know, Lori, did you want to hit on some of those, or like in terms of using natural history? You work in some a bit more of the rare disease space than me.
Yeah, but so the problem with using historical data is it's been shown over natural history data, it's been shown over and over again that as our treatments change, even just our approach to clinical care changes, the natural history data ends up not being valid. And in addition, and Robin, feel free to jump in as well, but in addition, when you put people in a trial, oftentimes they may do better just by the added attention of being in a trial, right? So there are a few more visits, there are more touch points, people feel like the quality of life is better, and so then people just do better in clinical trial. There was a study that was done in CMT where looking at a promising potential treatment that the placebo group actually ended up doing, both the placebo group and the treatment group ended up doing better than the natural history study, and there wasn't a significant difference between the placebo group and the treatment group. So there's cautionary things that need to be taken into account when you're doing that. Now, if you have a rare population, you may be able to use a run-in period before you start the treatment. There's other things that you can do depending on what the treatment is or the intervention is, such as doing alternating intervention and placebo in the same patient, and with a washout period. So, but I think anytime if you're doing a study that's going to rely on the natural history data only, you're going to have a pretty strong argument for that. Now, if you're doing something and you just want to look at, is there a hint of efficacy or a hint, like, again, you don't want, if you're doing, rather than doing an underpowered efficacy study, but you're doing like a feasibility sort of study or a safety, looking for safety signals, you could use the natural history data that as a comparator then. But I mean, to draw major conclusions, you have to be super careful. I don't know, Will, you want to weigh in on that? Or
Yeah, no, I mean, I think I think in the rare disease space, particularly if there are good cohort studies where you can really, and it's something about altering the course of disease progression, I think that might be something that is, it becomes, the more you know about something, potentially the better it could be used as sort of admissible historical data. In a non-rare disease like stroke, there's thousands of patients that have been represented in thrombolysis trials, but that data is relatively stale now because of the emergence of people with large vessel occlusions getting pulled out to actually get procedures that alter their their outcomes.
Yeah.
So to put too much credence in, say, 40% of people who get TPA are non-disabled is a little bit rough now. But on the other hand, there's not clean populations of thrombolytic treated patients in the thrombectomy era either. There's registry data and things like that, but registry data has a lot of sort of messiness to it. I think in the case of a not exactly rare, but not exactly fortunately extremely common disease of ALS, is that when you, and I don't want to presume to be an amateur neuromuscularist, but if you are looking at historical data on disease progression, the individual patient trajectories have so much potential noise in them that you really, it would be hard to design a study that is sort of, because the individual level variability and where somebody is going to be in 6 months is.
Although I will say, some certainly, like the Radicava study was based on looking at patients, the decline on the ALSFRS score, and predicting where they would be later in time. I mean, that is something that you can do, kind of what I was talking about the run-in, but Robin makes a really great and important point about, you know, just the way we take care of ALS patients now with pulmonary nutritional care and how that is changing over time. You know, the natural history data can be fraught with problems if you used it in that population. And we know that there was that nice study that was done that showed that actually the best treatment we have for ALS are the multidisciplinary clinics, which patients are now all, or not all in, but many patients are now in. And actually multidisciplinary clinics do change the trajectory of the disease. So yeah, so, and Robin is saying it's best to use placebo or standard of care. Standard of care plus placebo, and then and you would have a hard time getting NIH to swallow your study with just natural history data.
Yeah, and I think, you know, now, on the other hand, I think depending on like what the disease is, I will use a non-neurologic disease. I will use like a urologic disease. It rhymes with neurology. And when I was a resident at the Cleveland Clinic, if I asked the clerk to page neurology, there was about a 50% chance I would get urology. But I was talking to one of my local collaborators about doing a study to look at nerve blocks. Hey, nerves, nervous system, but nerve blocks to reduce the pain from renal colic acutely in the emergency department. And we have really good historical data on what pain medicines we give patients, how often we give them a second pain medicine. In terms of designing a trial where we do a nerve block, pretty hard, you know, it's not really ethical to do a sham control. So a placebo type controlled study is really challenging, but we do have this really well characterized data set of, you know, what's going on with their pain, how often they need a couple, you know, more than one dose of pain medicine. So, you know, that is a case where our understanding of our endpoint and the population is pretty good. And there are barriers towards using a placebo. There's also interesting work that I will not be able to do justice to, but there are things that you could talk to specific people about, where you can augment information from historical controls, right? Like, and say, you know, maybe do 5-to-1 randomization, use some information from prior controls, like you know, this has been called Bayesian augmented controls to a certain extent, so that you can get a little bit more mileage out of your control group and make sure that, as Dr. Gutman points out, that the control group isn't wildly different from the preliminary data that you're using to come up with an event rate from that control group. And I think, you know, Dr. Conwit definitely points out that in terms of in the efficacy space, to get to a final approval of a drug or a phase 3, you know, pivotal study, FDA is really often going to need placebo controls, at least in the drug space. You know, devices are a bit of a different scenario. Yeah, and then, no, and Dr. Conway also brings up an excellent point. You know, sometimes it isn't ethical to use a placebo if there's an established treatment. So comparison with standard of care is the best option. Yeah, no, definitely. For, you know, certainly we would never dream of doing a thrombolytic stroke trial with a placebo control. But in order to find something that's incrementally better than alteplase, that is harder, obviously, than finding something that was, you know, alteplase was better than control by quite a bit. Finding something that's better than alteplase is unlikely to be as much better than alteplase as alteplase was better than control. So studies where there is an existing treatment that is effective tend to be harder to do, because you're going to be looking naturally for a smaller effect size. Those are excellent points. All right. If anybody has any last minute questions, please feel free to put them in the chat. I think in terms of my sort of goals and objectives for this talk, I did want to try to cover, a few different areas. I know that Courtney will put in the chat the evaluation. I know this was a little bit more kind of stand-up clinical trial design. Kind of we sort of riffed off of what your needs were, and hopefully we've answered some of your questions here. There are also the office hours to bring more that are in a more cloistered environment within the course for those who are part of the cohort this year, to bring any questions to the broader faculty as well. And I did put in those two links in the chat to the best biomarkers handout, which is a good way of thinking about the different types of biomarkers, and then a good definitional paper by Lahana Thabane on pilot and feasibility trials and what you should be looking for in those studies, and what a bit of the nomenclature is. All right, well, Dr. Conwit, Dr. Gutman, any other things to add at this point in time?
No, thank you for everybody who participated. Thank you for your questions. For those of you in the course, please come to office hours if you have other questions or you want to get some input from one of the course directors. We'd love to see you there.
All right, great. You all have a good weekend.
Thank you, everyone. Have a great day.